Thank you, Heather, and welcome everyone. So as Heather said, my name is Sophia Johnson, and I lead the Health Officer Liaison Program here at DHHS. Just a little bit about me. I received my master's degree in public health from the University of New Hampshire, and then I proceeded to work at the Manchester Health Department as field inspection staff, and then I transitioned to my current role at the state. So while the pandemic was certainly stressful for all public health professionals, I do like to say that I'm grateful for my experience leading this program prior to the pandemic and then through the pandemic. So today I want to talk to you a little bit about our experience in the pandemic, and it will be through the lens of the local health officer, so a much more narrow view than we've been talking about so far this morning. Let's see if I can transition my slide here. Okay, so this session is intended to first describe the authority of the local health officer, clarify the role of the New Hampshire Department of Health and Human Services, and then from here on out, I'll just refer to this as the department. So clarify the role between the department and the municipal officials in responding to COVID-related compliance complaints, and then discuss legislation initiatives as a response of health officer involvement during COVID. So I've organized this presentation into 3 different sections. The first section provides an introduction to the normal duties of the local health officer. The second section is intended to provide an overview of the overlap of the work between the state and these local officials. And then the last section provides an overview of the aftermath of COVID. And I know we just talked about that COVID is still continuing, but again, through the lens of the health officer, we're finding that their work is really starting to subside in this area. So I like to start with a case study. This highlights the importance and authority of the local health officer in their communities, and this actually did take place in a New Hampshire town. The town received a call from a disgruntled neighbor that the property adjacent to theirs was accumulating a significant amount of trash. Additionally, they report that from what they can see, this trash also extends to the indoor environment, and there are children who reside there. So a lot of concerns. So these were some of the pictures that the health officer took of the exterior environment. You can see a lot of buildup of just different types of debris. There are oxygen tanks, so just a wide range of trash on the outside of the property. And this is just one picture of one of the rooms in the house. And you'll note that the trash is all the way up to the windowsills. So significant hoarding concerns on the indoor environment as well. So the local health officer went out to do an inspection and was allowed on the property. So including in the traffic violations that they found, the health officer was able to verify concerns in the indoor environment as well. And the health officer did find that DCYF had recently taken the children out of the home. And also with her inspection, she was able to identify some continuing health issues in the home that were able to corroborate DCYF's investigation into the family. In addition to that, the health officer identified numerous housing code violations that were putting the residents in danger. So including in those hoarding conditions, there was pest activity, there was infrastructure instability, so a wide range of issues. And then finally, the health officer was able to identify activities that would lead her to believe that there was drug manufacturing taking place in this house. So long story short, the health officer was able to first coordinate partner agencies to implement a more comprehensive response to this issue, including work with the fire department, local police, DCYF, and also specialized cleanup agencies. The health officer was able to secure an administrative inspection warrant to conduct additional inspections into the home to provide more evidence of this drug activity that was in fact occurring. And she was ultimately able to order the home to be vacated. It was not safe for anyone to be in that home. And now the health officer is currently working with the EPA to address some of the cleanup procedures that need to happen because this was in fact identified as a brownfield. So a really good overview of not only the work of the health officer, but who they partner with kind of on a more daily basis. So health officers respond to environmental hazards that impact the quality of life of the resident that's dealing with that issue, but these hazards also have the ability to impact the community around them. So these hazards can include pest infestations, septic failures, hoarding conditions, drinking water issues, and many others. So their work really showcases the public health goal of protecting the whole community. Local health officers in New Hampshire are municipal officials whose role, again, is to ensure those sanitary conditions are present in their community. They're nominated by their town selectmen and then appointed by us at the state. So across the state, health officers serve in a variety of capacities. Some are paid full-time, some are part-time, some are volunteer. Again, it really runs the gamut, and that's what this graphic on this slide is showing. We know that health officers also hold other positions in their municipality. So if they're full-time, they're most likely the building inspector and the health officer, or part of the fire department and the health officer. So they juggle a lot of roles in their community and wear a lot of hats. But because of this, they're really well connected to the residents, and they're an important point of contact for the local communities. So I just want to, again, briefly provide a quick overview of the statutes that give health officers responsibility and authority to enforce. And this will be important later as we talk about COVID. So some of the main RSAs that give health officer authority are RSA 128 that says they shall make sanitary investigations. They're also given ability to enforce public health laws and rules. RSA 147 gives them the ability to inquire into all causes of nuisances and other causes of danger to the public health. And then that same RSA also gives the ability for them to make local regulations. So based on this kind of division of power, they have broad authority to inspect, broad authority to enforce, and then also authority to make local ordinances. So the language of the statute is broad, and in practice, this translates into numerous areas of environmental health that they respond to within their municipalities. And I want to point out most often that they respond to nuisance complaints. They do sanitary inspections of housing, schools, daycares, foster cares. And because of all of this numerous work, they work with a lot of partners across the state. So on the right-hand side of the slide, you'll see some of those partnerships that I've outlined. And oftentimes these health officers are the eyes and ears on the ground for these different state agencies. So in the absence of a pandemic, the health officer has a unique relationship with the state. The state appoints health officers, but health officers are ultimately an employee of the town. So they're subject to their HR policies, their payment structures, governance, and things like that. So health officers can act independently of the state and respond to community complaints and enforce local laws. And in this role, they can report issues that they see to the state that the state may not be aware of. Conversely, the state recognizes that they're an important local resource, so the state can also request that the local health officer act as their agent in different situations. So for example, health officers conduct septic investigations on behalf of DOE, the DES, and they do school inspections on the behalf of the DOE. So in the absence of a regional public health structure or a county structure, the health officer really is an important person in that local public health response. So now that we have a very quick and hopefully a little deeper understanding of the role of the local health officer, let's jump into COVID-19 and the pandemic response now. So the two questions that we will be looking at during this section are, what was the role of the health officer, and what was the relationship between the state and the local health officer? So we talked about the authority of the health officer, but how does this translate into communicable disease? And before we jump into COVID-19, we can talk a little bit about the powers that health officers have under communicable disease situations. So RSA 141C is the statute that outlines the procedures and response to communicable disease. In this statute, health officers are given a few responsibilities that I've listed on this slide. First, they are to assist the commissioner of DHHS when requested in establishing isolation and quarantine. They attend meetings with the commissioner when requested and inform the commissioner if they identify any substantial non-compliance with isolation and quarantine orders. That's it. So what do we take away from this slide? Prior to COVID-19, health officers had very little responsibility in terms of communicable disease. They're not required to complete investigations. They're not required to set up clinics. They aren't required to perform contact tracing. Really, up until this report, their only action is at the request of the commissioner. And that really hadn't happened in a long time. So because of this, a lot of health officers across the state had no experience responding to communicable disease situations like this. And then COVID hits. And we know that this pandemic was unprecedented. across the country, across the state, and very few public health officials had, experience responding to something of this magnitude. And I'm, again, primarily speaking from a local public health perspective here. Up until this point, we talked about health officers serving for their 3-year terms, mostly responding to sanitary conditions, hadn't engaged in something like this. And we know that some health officers are part of the fire department, are part of their emergency management director team. But this is not universally the case. So in March of 2020, the Governor Sununu declares a state of emergency in the state of New Hampshire in response to COVID. And as part of this order, there were a few different partnerships that were mobilized. And I've identified them here on this slide. So we have 211 that handled all the COVID-19 calls. State employees were repurposed to complete tasks necessary to address the impact. The Division of Homeland Security and Emergency Management provided assistance to local towns. There was an emergency operations center that was established to assist in the response as well. So we see the rise of kind of these major players at this point. And I think it's important to talk about too, what does the state of emergency mean in New Hampshire? So a state of emergency can be declared by the governor for reasons of a natural, technological, or man-made disaster of major proportions. A state of emergency can also be declared by legislation, but that didn't happen in New Hampshire. Ours was as a result of this governor order. A state of emergency automatically ends after 21 days unless the emergency declarations specifies a shorter timeline. But the governor or the legislature can renew it indefinitely, so as many times as they want. And this is what we saw happened a lot in the pandemic. What's important, I think in this slide, what's most important is the powers that being under this status provides to the governor and also to DHHS. So the governor has additional abilities to move different materials, take control of emergency forces, and then suspend rules and regulations, and really anything other to help promote the safety and welfare of the residents. DHHS can also order isolation and quarantine and treatment for individuals. And with written approval from the governor, DHHS can order towns or really any public or private buildings to close. This power does not extend to towns. So it's really the governor and DHHS that we find that has these additional powers. So from here on out, again, we're going to be talking about a very narrow perspective of the state response. Obviously, the state response was large and engaged various partners, but for the purpose of our talk today, I really want to dig into the parts of the pandemic that overlapped with the work of the health officer. And over the course of the pandemic, the governor used different tools to curb the spread. In addition to that massive contact tracing effort that we know that was going on. So I want to highlight a few tools that will impact the health officer. First was his use of executive and emergency orders. The executive orders were primarily issued to extend the state of emergency, and we saw that many times. The emergency orders were used to outline things that, or orders that regulated activity, enacted temporary allowances, and things like that. So these orders included directives like prohibition on gathering sizes, the expansion of telehealth services, remote instruction, and these orders took effect as laws and could be enforced as such. Now, the next tool that the governor used was the creation of this universal best practice document and also corresponding industry-specific guidance. So this guidance was created by a task force of industry representatives, health professionals, legislators, and a host of other partners. And the guidance was intended to provide businesses and individuals with best practices to reduce the spread of COVID in their realms. So there was food specific guidance, there was day camp specific guidance, and then also guidance for individuals, if you have COVID, what does the isolation and quarantine look like for you? So we'll get into a little bit more of those later, but that was, again, a major tool used by the governor. And then finally, DHHS set up a COVID-19 website to house all of this information and to house all of this guidance, in addition to other clinical information and case reports. So let's talk about these emergency orders, because this is really where we're getting to the crux of our conversation. This graphic is by no means comprehensive of all the different emergency orders that were issued, but the timeline gives you a little perspective on when certain directives went into effect. Specifically, I've chosen to highlight the emergency orders that will impact the work of the health officer. So you can see that there were prohibition on gathering sizes, closures of non-essential businesses, face covering requirements, and these emergency orders were issued in reaction to factors that, from available science, CDC recommendations, case counts, and things like that. And they tried to address different issues that arose at the state at different levels of the pandemic. And we found that by the end of the pandemic, there was a total of 90 emergency orders that were issued, and the state of emergency was renewed 21 times. So while the pandemic started in March, we see that businesses were allowed to reopen in May, June under restricted operations and abiding by their industry guidance. So Emergency Order 52 outlined this limited reopening process. And those guidance documents were not static by any means. So they changed every so often, depending on the newest guidance coming out from the federal government or from CDC or even from DHHS. So, in short, it was really hard for individuals and businesses to kind of track what they were required to do or what was recommended to do during the course of the pandemic. So, you can imagine what it was like for people to keep track of these different changes, the different versions, in addition to the other pandemic requirements. They were very helpful for businesses to understand how to operate safely, but it was certainly a challenge to implement this guidance across the state. So we have all of these emergency orders. And the natural question is, who enforces it? Who responds to complaints of noncompliance? Who goes out and does the compliance inspections? And we found that there were concerns. There were a lot of concerns. We received calls from individuals that were complaining that places were exceeding the numbers of the gathering size. We received complaints that individuals weren't adhering to isolation and quarantine guidelines. Businesses were not encouraging staff to wear masks or didn't have mask wearing policies. So, we received these complaints and they really range from individuals to businesses. But again, who responds? Who has that authority? So if we remember from early in our conversation, the pandemic started in March and businesses were closed at that time and not allowed to reopen until end of May, June. And it wasn't until June that we see some mention of enforcement powers during the emergency. Emergency Order 52, there's a clause that says the New Hampshire Department of Public Health and state or local police shall have the authority to enforce this order. But what does that look like in practice? For one, I can tell you that DPHS did not have staff capacity to respond to complaints across our state. Our team worked 7 days a week in contact tracing efforts, clinical initiatives, education campaigns, and there was no extra staff that could travel to Errol to talk to a business who didn't want to enforce mask requirements, or we couldn't go out to Hampton to verify if someone was, adhering to social distancing guidelines. It wasn't feasible. But what about local police? They were also given authority in this order. And in theory, it sounds practical since they respond to community concerns of noncompliance in other areas, but this is a communicable disease situation. And responding to these types of concerns requires knowledge of droplet-borne transmission and how to properly assess droplet-borne transmission risk, as well as knowledge of all that industry guidance that we talked about, clinical recommendations, and public health protocols. And I think many people think that that's too much to ask of local or state police. They certainly have a role, but it wasn't feasible to rely solely on them to enforce compliance to all of these orders with their kind of specific knowledge base. So here's where we really get to the crux of health officer involvement. We know that health officers are local public health resources who can respond quickly to situations in their communities, and they're accessible to their community and they're known by their residents. Even if it's basic, they have some familiarity with public health knowledge. And as a result, that we saw as early as February 2020, so even before the state of emergency was issued, health officers began receiving calls from their constituents. And this communication between residents and health officers escalated quickly as the state of emergency went into effect and businesses were closed. Health officers received calls from residents concerned about local businesses or other local residents who weren't adhering to requirements. And most of the time, we found that the health officers did go out and inspect and educate as a result of, the community complaint. but they did so voluntarily. Remember back in an earlier part of our conversation, we talked about the powers given to health officers in a pandemic, and enforcement authority was not one of them. However, DHHS, seeing that this was happening, they did ask health officers to follow up on local concerns and educate individuals and businesses on those best practices, but we could only ask this of them. We couldn't mandate it. And again, most of the time they did go out and engage. And in turn, our office worked very hard to keep them updated on the changing guidance and different orders so they could respond appropriately. We went and provided virtual webinars, and we had constant communication through our listserv. But it's important to note that this relationship wasn't dictated or outlined anywhere in statute. It was really a product of this unprecedented event that we had to respond to in the moment. So this graphic only begins to scratch the surface of health officer work during the pandemic. From the month of January to December, our office kept a log of all the calls we received. And these calls are from health officers who themselves have to respond to a situation in their community, but they don't know how to act or they don't know how to respond. So they call us for assistance or they call us for help. So what's not captured here is all those times that the health officers responded and they already knew what to do and they didn't contact us. So what I want to point out here is that our office usually receives about 220 calls a year from health officers looking for guidance. And this year in particular, we received 729 calls. That's over a 330% increase of normal volume, and over 500 of those calls were COVID specific. The COVID calls are identified in the off-white color. And you will see that the calls start to escalate around March when the pandemic really started to take off. Then again, there was a spike in May when businesses that provide essential services were allowed to reopen. And then again, at the end of the year when regulations were relaxed, but face masks had to be worn in public places with physical distancing. The yellow line represents the average calls that we receive per month, and that's about 20. And then this orange bar at the top of the graph shows calls that we received from health officers that were related to other issues. So these are calls related to their normal functions. So if they had a septic failure or a hoarding condition, and we find that over the course of the pandemic, we're still seeing them responding to those other situations at a normal rate, if not more so. Because again, we on average see about 20 calls a month, and most of these months were exceeding that. So we're seeing their workload substantially increase. So this graphic depicts the types of calls that we received. So in what areas did health officers have questions when they called us? And we found that the #1 industry that they responded to most often that they had questions about was food service. And I think this was because the food service guidance in particular, when these businesses were reopening, changed very frequently. They also had questions about retail businesses. And interestingly, we received a lot of calls from municipalities asking how does this guidelines and how do these recommendations apply to municipalities, and do they have to abide by it in the same way that businesses or individuals do? So again, this kind of word cloud depicts all of those different industries that we find health officers went out and did investigations on, and they really kind of represent most industries across the state. So let's look at that timeline again. We have all these issues, and when is there mention of enforcement? Well, we know that it wasn't until July that DHHS finally issues a memo recognizing that they require the assistance of local health officers, and they're requesting more formal assistance from health officers to conduct these types of compliance inspections. But it isn't until June that they're actually given explicit enforcement authority. So July, they're given the authority to inspect and follow up on these compliance concerns, but then August, they're actually allowed to enforce and have that enforcement tool to respond to continued non-compliance. So what's important for us to keep in mind as we think about that is a lot of the response to COVID and a lot of the calls have already taken place by this time. And we saw that the closing and reopening of businesses had already taken place, stay-at-home orders, so many instances where health officers were called in to intervene without this formal recognition and without this formal authority. And our program worked really hard to advocate for this statewide recognition and legitimacy of the health officers' work. And we hope that in future pandemics, because of our work during this pandemic, that this role will be clarified for the future and allowed to be enacted much sooner in future pandemics. So if we talk about that memo that was issued in July from DHHS, the department states that DHHS requires the assistance of health officers to conduct sanitary inspections to help compliance with public health guidelines. This memo also outlined the process for recommended response to compliance inspections. And first, they were asked to do an assessment. So verify that there is in fact an issue to be remediated or addressed. The health officer should really be the leader in areas of assessing public health impacts from the spread of COVID. And then next, if you do identify a violation, the guidance was to perform education. The primary goal of this whole response was to build public trust and promote community education. So we didn't want to go in there and say, you're violating the guidelines, so therefore you're going to get a fine. The perspective was really try to educate people so they can engage in voluntary compliance. Finally, there is that enforcement ability that health officers had, but once you got to that point, there was a warning letter, there was another follow-up inspection. So really there were a lot of opportunities to fix the problem before it got to that enforcement end. And what we found happened most of the time was that health officers didn't actually engage in that enforcement. At that point, they passed it off to local police with all of the documentation of what has happened up until this point, or they passed it off to the AG's office for that inspection. So there was kind of this relationship from the health officer giving information to the police and the AG, but we also found that a lot of the times, if there were concerns or complaints, people would call the AG's office or police directly, and then they would send them back to the health officer. So there was this kind of reciprocal relationship that developed between enforcement and the health officer to make sure that that inspection was done and that education was done prior to any hard enforcement measures. So this is a case study that kind of illustrates the relationship of the work of all of these different agencies together. In July of 2020, we found, the department was alerted of a controversial tent revival event that was scheduled to take place in August. And the organizing group had held a similar event in another state, and there was evidence of widespread disregard of public health protections during that event. And the concern was that a similar situation would end up happening here in New Hampshire. So in early talks with this group, the town reported that the group again expressed this indifference about the public health guidelines and requirements that we had enacted in our state. And when we received this complaint, we reached out to the health officer to really follow up with the group. And the health officer kind of created this little coalition where he worked with the town, the AG's office to provide guidance and kind of continuing encouragement to this group to follow recommendations. And this process even made headlines to the point where the governor issued a statement encouraging this group to follow the recommended guidelines. And what ended up happening was prior to the event, the governor passed an executive order that required people in gatherings of over 100 to wear masks. So when this event did take place, the health officer was on site to verify compliance, and for the most part, the event did take place safely. So there was, this potential crisis that was averted because of the work of all of these different agencies. And while I would love to go into more depth about specific case studies of noncompliance and the success a lot of the times of the intervention of the health officer, we just don't have time today. Happy to discuss that at the end, but really what I want to focus on now is what happened as a result of this partnership between the state and local entities. And unfortunately, it's really hard to quantify how many times different officials responded to issues of noncompliance. And this is really because the data is so decentralized. We have data here at the department. The AG's office has data on how many times they were involved in different situations. The local police have data, and that data has never been centralized or aggregated. So again, we don't really know the full extent of how many times this kind of coalition responded to different non-compliance situations. So even out of all these calls and the uncertainty of kind of the final number of how many times this group was enacted, there were only 8 businesses that were ever fined for continuing non-compliance. And those fines totaled about $10,000. And this is surprising, but I really think it speaks to the emphasis on education and voluntary compliance as opposed to hard enforcement. We can imagine that these compliance concerns resulted in hundreds and hundreds of calls, but only 8 businesses were ever fined. And in the end, those 8 businesses ended up not having to pay their fines. 3 of them appealed and didn't have to pay, and then the 5 other businesses were ultimately refunded their money. So that's a whole nother discussion that we don't have time for today, but these fines ended up being extremely controversial. And while some claimed that these orders were unconstitutional and was, an overreach of government power, others advocated that refunding these businesses really incentivized lawbreaking and was an affront to those citizens who diligently followed the public health guidelines over the course of the pandemic. So in the end, the governor, who did oppose these refunds, made compromises and did refund the businesses money. So quickly now, because I know we're getting to the end of our time together, we'll talk about what are those what's the legislative aftermath? And with that controversy in mind that we just talked about, we'll move into this next legislative season. And so as cases began to fall across New Hampshire and easement of restrictions took effect, we began to see the implications of the pandemic on our local public health officials. And again, talking from a local public health perspective. In the aftermath of COVID-19, the questions about local power and authority arose. And so we're not going to talk about state power and kind of the issues that came out of that, but what did these fines, what did that enforcement power mean for the perception of health officers on the ground? And COVID-19 proved to be an overwhelming challenge, as we talked about a little bit, for many public health professionals, while kind of simultaneously providing this really unique opportunity to showcase the importance of this underutilized and oftentimes unknown local resource. So let's first talk about the benefits of COVID-19. So as a result of this pandemic, the health officers were catapulted into a spotlight in a way that they had never been before. Up until this time, their work was primarily unseen and in the background. I mean, responding to rodent infestations and septic failures is not glamorous when you compare it to, firefighters putting out a house fire or as visible as police driving around in their cop cars. Again, this is primarily an unseen local position. So when health officers went into local businesses or spoke with community members about isolation protocols, their position received a level of awareness that they had not had before. And this awareness also extended to partnership opportunities. So in responding to COVID-19, health officers worked with state and local emergency response groups, the AG's office, like we talked about, Department of Homeland Security, and all of these agencies relied on the health officer for their investigations and local accounts of what was going on the ground. Awareness and collaboration, 2 benefits that will certainly impact the work of the local health officer moving forward. And it's our hope that we can build upon this new foundation and continue to break down the veil that currently hides health officer from public views. Now, on the other hand, similar to health professionals at all levels, I think, COVID-19 brought significant strain. The 2 Bs, we say, burnout and backlash. The pandemic raged for over a year and required constant attention by public health professionals. Guidance was constantly changing. New emergency orders were enacted, then removed, and then enacted differently. Outbreaks popped up across different communities, and residents were rightfully fearful and businesses were distraught by the significant impacts it had. And we see that the health officer was really in the crossfire of some of that, discontent and fear. They were the ones who were asked to visit businesses who were reportedly not complying. They were the ones who were asked to share information with communities or respond to people who didn't want to follow the quarantine guidance. And all amidst this constantly changing environment. And it was really exhausting, and it was frustrating, and oftentimes very contentious too. And we know that from the beginning, this pandemic was very political, and the work of the health officer to control the spread and enforce those guidelines was often met with cynicism or criticism or arguments. It was challenging for the health officer to complete their work when a part of the population, especially in New Hampshire, was very critical of the pandemic in general. So, there was a group of people who was skeptical even of the pandemic's existence or was against vaccination. So as a person in trying to enforce the standards, it was incredibly draining. And I'm really surprised that we didn't see more resignation from this population, but we did see resignations, and the number of health officer vacancies since this time have really increased. We see this happening at the same time as some retirements, so it's challenging to definitely pinpoint this increasing vacancy rate to burnout only, but we did see an uptick in vacancies that we did not expect after the pandemic. And we're still dealing with the implications of this. We're still having a hard time recruiting health officers now into these open positions. So in addition to that challenge, there was a significant legislative response. So state officials, local municipalities, residents are becoming aware of the role of the health officer that we talked about. And they're becoming more aware of the role they play in their communities and also the power that that position potentially has. So in addition to statutory enforcement powers that are already given to them, health officers now kind of became the local face of COVID-19. And people started asking, who are these officials? What powers do they have? Do they have the qualifications to perform this role? What are the limits of their power, and what should be those limits? And here's where we start to see the development of two different camps of thought coming into this legislative season. The first camp thought that there was a need to improve training requirements for health officers and improve collaboration and communication between state and local officials. The other thought was that the health officers have too much power for the training and that they have, and this should be taken from them. They have too much power basically for their knowledge base, and the law should limit the work of the health officer. So in the next few slides, we'll talk about what that meant for the legislature. So capitalizing first.
I have it
on this, so capitalizing on this momentum, the New Hampshire Health Officer Association thought that this was an opportune time to look at the statute that guides the work of the health officer and improve training requirements and improve communication between the health officers and their partners. So they pulled together a group of stakeholders, and their resulting work was this bipartisan House bill that was proposed in the 2021 legislative season. And I have on this slide an overview of how that bill moved through the legislature. And why I like it is because it showed, first of all, how quickly and relatively easy it moved. And you can see that the votes were almost unanimous. So the legislature agreed that there was this need for training and communication requirements in the bill. So what did House Bill 79 address? And it addressed health officer appointments, reporting requirements from local boards of health. It increased training standards. It also required the Health Officer Association to do reporting. And there was also an opportunity for health officers to receive more confidentiality or confidential data around communicable disease. So this bill did pass, and in summary, health officers must now complete 3 hours of training in their first year to ensure a basic level of competency among all of the different environmental health topics that they respond to. Local boards of health must now meet at least once a year to discuss local readiness to respond to public health threats. And then the New Hampshire Health Officer Association has to submit an annual public health readiness report to the joint it's the Joint Legislative Oversight Committee. I always screw that name up. So in short, now there's this legislative platform for municipalities to talk about their readiness to respond to public health threats. In addition, what's really important is that health officers are now given authority to enforce orders that are issued pursuant to RSA 447, and that is the RSA that outlines a state of emergency. So in future pandemics, if the governor issues more emergency orders, there is an enforcement mechanism already written into that declaration for health officers. And again, health officers now have the ability to receive confidential data relating to communicable disease if they have the appropriate training and an agreement with DHHS. So the first bill that I want to talk about today that is proposing to, this was the bill that's proposing now to limit the authority of the health officers. So now we're going to transition. That first bill, House Bill 79, that we talked about, really was a legislative win for health officers. They received more training, more authority to respond, and a platform to communicate their readiness. However, while that bill moved through, we also saw two other bills that sought to take away power, and this was the first one. This was a partisan bill that was issued in 2021 and sought to remove health officers' ability to make local regulations relating to public health. As we talked about in some of those beginning slides, health officers have a pretty broad authority to make local regulations, and this bill sought to narrow the scope of that ability and limit it to a few specific areas, as pointed out on this slide. While it passed the House on partisan lines, it was ultimately deemed inexpedient to legislate and voted against in the Senate. So what I will say that came out of this bill is that there is a population of residents who didn't like when towns passed local mask ordinances, and that's where we see that this bill really came out of. There were certain people who didn't want towns to have the ability to create local mask ordinances, and they believed that it came out of health officers' ability to create local laws and local public health laws. But in fact, we found that when New Hampshire towns did, if they did enact local mask ordinances, it never cited this statute. So town councils created that local ordinance without even using the health officer, but I don't think this particular bill sponsor was aware of that. The second bill that we'll talk about today was directed towards city health officers. There are 13 cities in New Hampshire who operate under different RSAs than town health officers. So this bill was an attempt to mirror the previous one that we talked about and remove, again, city health officers' ability to make local regulations. And this bill passed the House along partisan lines as well, but was ultimately referred to interim study in the Senate, and it never went into effect. So while these bills moved through the legislature, there was an effort to get state and local testimony in response to these changes. And then the first testimony that I want to share is from a New Hampshire city, and I won't read it because we don't have the time, but basically it's saying that local lawmaking ability of health officers is a really important tool for health officers to address the unique concerns and issues that arise in their town. So in the language provided by that bill sponsor, it was so specific that if you didn't have a pest problem or a septic failure, then health officers couldn't make regulations around that. But what if they're having, really bad drinking water issues? The health officer wouldn't have the ability to regulate that. So that's what this town was saying, is that it is it's too limiting for town health officers not to have that ability. And then what was really important was that DHHS in this quote from their testimony was that, yes, we don't want to see a rollback of any power that's currently given to the health officers either. They have a certain statutory responsibility and obligation to their residents, and local lawmaking enables them to do that. So I'm going to start wrapping up here because I know we have a few more minutes. So what's important to take away from this legislative season was that there was a consensus that health officers are an important municipal tool to provide public health options, for New Hampshire, which doesn't have a lot of local public health structure. The department supports the broad authority provided to health officers, yet did recognize that there is a need for improved training, and that the department also supports the autonomy of local towns and cities to create and ultimately enact local public health codes. So while we may be coming out of COVID and we're pretty happy with how the last legislative season ended, we are gearing up for this year, and we do know that the sponsor who enacted or proposed those two laws is coming back this season with a revised bill to continue to try to limit the role of the health officer. So we're following that pretty closely, and we have a team from the department, from the Municipal Association, and from the Health Officer Association to track and then respond to those bills when they do finally come up. So we covered a lot of information today, and in review of the COVID-19 pandemic through the lens of the local health officer, let's just step back and reflect a little bit. We know that New Hampshire doesn't have a robust county or regional public health structure. So in most cases, health officers are some of the only local public health resources and are an important ground professional for the department and other agencies to respond to local threats. COVID-19 brought a greater awareness to the importance of the local health officer, but also highlighted their enforcement power, and as a result, may have had created more opposition for the position than was originally there. At least for my program, we focus on improving the knowledge and skill set of the local health officer to continue building support and awareness of the position. We're working on integrating their work with the regional public health networks. To kind of bolster response initiatives at the local level. This is just a little bit about the New Hampshire Department's Health Officer Liaison Program that I lead. We have a legislative mandate to appoint and support local health officers. So our work is primarily in 3 areas. We appoint health officers for the towns across the state, we provide technical assistance, and then we provide training to health officers. Here is my contact information. And I think at this point, we can open it up for questions. Thank you very much.
Thank you so much, Sophia. That was a great presentation with a lot of information, and especially helpful for me in Maine to learn, as we lack, we're in a similar situation with our public health infrastructure where we lack a lot of local it doesn't exist at the local or regional level, similar, but just relying on some boards of health and local health officers. So really appreciate that. As a reminder, folks can go ahead and put questions in the chat, or if you'd like to raise your hand, you can also come off mute and ask a question. We have some more thanks coming up in the chat to you for the presentation. One of the questions we have, you talked a little bit about some of the bills working towards having requirements for LHOs. But are there any specific requirements right now to be a local health officer or background qualifications that they need for hire?
Yeah, it's a great question. And up until the bill that passed last year, there were no requirements. So the town auto mechanic could apply for the health officer position, and as long as he passed a background check, he would be able to, fulfill the position. Now there's that 3-hour training requirement that once you're appointed into the position, you have to go through our 3-hour training to give you an introduction to your role. But that competency level is still something we're working on. And in law, there are no other requirements to be a health officer.
Thank you. All right, we have a few more questions. So this one goes a little bit in line with that this person's surprised to hear that 1/3 of health officers are volunteers. How does that affect holding them to those requirements?
Yeah, it's really challenging because health officer competency ranges. So we have city health officers in Manchester who have master's degrees in public health, and yet we have small towns with 500 people who, force this guy from the Board of Selectmen to be the health officer because that's the only person they could find to apply. So the health officers that are volunteer, we do find that there's a harder time getting them to come to those trainings, but there is now a requirement for them to attend the training. So we have in place a structure to monitor who's registered and who's going through that training. And it's new for us. I mean, this is in the past year. So we're trying to improve that infrastructure to make sure that everyone is moving through that training.
Great, thank you. And I know in Maine, we often have our health officers don't work very many hours a week. So it also limits what they're able to do, and the pay isn't so great either.
Yeah.
The next question, is there any movement toward regional health officers, particularly for smaller towns, to work together to hire qualified staff?
Yeah, so the Lakes region in New Hampshire received a grant last year or 2 years ago to have, it was a 2-year funded grant for a regional health officer for the Lakes region. And what we found was that some of the towns didn't want to give up the authority that they had for oversight for their health officer. So getting the towns to agree to having one regional health officer was a challenge that I don't think we didn't expect. And that could just be a Lakes region challenge. So we haven't implemented that across the state yet. We kind of wanted to see what would come out of the Lakes Region pilot. And then actually that person ended up having medical issues and had to resign from the position. So it hasn't been done yet. It's still something we're thinking about, but the buy-in from the towns isn't there yet.
That's very helpful. Thank you. This next question is around data. What types of data can support various mandates for masking, et cetera, in New Hampshire?
I'm not really sure how to answer that because, again, the local mask ordinances that went out or that were approved by towns, most of the time didn't come through our office, and most of the time didn't go through the health officer. That was a decision made by the town based on data that I think they were getting from the COVID-19 website that the state had, or the available data on that website. So we really weren't involved in a lot of those mask ordinances. So when that law came up, taking their power away because of mask ordinances, it was a little surprising because, again, health officers didn't proactively request those mask ordinances in most situations.
Great, thank you. Again, very helpful. This one is a very, I think, hopefully easy question. Is there a list where folks can access the contact information and identify their health officer?
Yes, so the department's health officer liaison program has a button that pulls up a PDF of all of your all the health officers, their contact information. I think that's in my slide deck here. So when the slides go out, you'll have access to that webpage.
Great, thank you so much.
Mm-hmm.
We do have a few more minutes. We are able to go a little over 11. Are there any other questions from people? Not seeing any in the chat. But again, I think the contact information was provided. So hopefully, Sophia, you'd be okay with people following up afterward if questions do come up. But thank you so much for your presentation this morning. It's been really helpful, really informative, and it's hopefully given some people some action items and steps to take in their public health work.
Yeah,
So thank
thank
you,
you.
everybody. I believe we will start again in the breakout rooms around 11:15. So we'll see you back there.
And
then.
I just want to say, if now kind of knowing the health officer work a little bit better, if there are partnerships you think that are possibilities in your areas, please let us know. I think we still want to work better with medical systems as well, because a lot of the times, especially in hoarding, when health officers respond to hoarding situations, that hoarder is usually a frequent flyer of the emergency room. So how can we collaborate to improve kind of this comprehensive care? Because the health officer doesn't want to go in and just evict the person. They want to make sure that steps are taken to make sure that that person can live safely in their home, but we need to work with the right partners. So coming out of COVID, that's something that we really want to build on. So if you have suggestions for partnerships, we would love to entertain that.